If you listen to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we will go through the NICE guideline on acute asthma, or NG244, focusing on what is relevant in primary care only. Like in chronic asthma, the NICE guideline on acute asthma is a joint effort by NICE, BTS and SIGN. A link to it is in the episode description. In this episode, I will just focus on the initial assessment of acute asthma in children. In the last two episodes, I covered the initial assessment and treatment in adults, and in the next two episodes, I will cover the treatment of acute asthma in children and lessons from asthma deaths. So stay tuned for those. Right, let's jump into it. Acute asthma in children, particularly in those under 5, can be challenging to assess. In this age group, intermittent wheezing attacks are often triggered by viral infections, and the response to asthma medication can be inconsistent. Children born prematurely or with low birth weight are at higher risk of recurrent wheezing episodes. We should also consider other potential diagnoses, which may include aspiration pneumonitis, pneumonia, bronchiolitis, tracheomalacia, or complications from underlying conditions such as congenital anomalies or cystic fibrosis. This guideline is intended for children with acute wheeze related to underlying asthma. It should be used with caution in children under 2 years of age who do not have a confirmed asthma diagnosis. It is not intended for children under 1 year unless directed by a respiratory pediatrician. Additionally, these guidelines should not be used to treat acute bronchiolitis. Let's now look at the different measurements and investigations that apply to children. And let's start with the assessment of oxygen saturation and pulse oximetry. Accurate pulse oximetry using pediatric probes is essential in all children with acute wheezing. Pediatric pulse oximeters can involve the placement of a small probe on the finger, toe, or earlobe of an older child. But in neonates and infants, probes may also be placed on other parts of the body, such as the palms, feet, arms, and cheeks. From a general perspective, intensive inpatient treatment should be considered if saturation of oxygen remains below 92% in room air after initial bronchodilator treatment. Next is peak flow measurements, which can be useful in children, but are only reliable in children who are familiar with the device. Also, when measuring peak flow, we should use the best of 3 measurements and express it as a percentage of the personal best when known, or predicted if not known. A peak flow less than 50% of predicted or best, with poor improvement after initial bronchodilator therapy, suggests the need for more aggressive hospital management. Next, chest X-rays are not routinely indicated in children with acute asthma. However, we will consider a chest X-ray if we suspect subcutaneous emphysema, persistent unilateral signs which may indicate pneumothorax, lobar collapse or consolidation, or in cases of life-threatening asthma which is not responding to treatment. Now let's move on to the clinical assessment, and for this we will look at the different categories of acute asthma in children. And we will start with moderate acute asthma, which is when the child is able to talk in sentences, has a saturation of oxygen 92% or over, a peak flow 50% or over of best or predicted, a heart rate of 140 or less in children aged 1 to 5, or 125 or less in children over 5 years, and a respiratory rate of 40 or below in children aged 1 to 5 years, or 30 or below in children over 5 years. The next category is acute severe asthma, which is when the child is too breathless to talk or feed, has an oxygen saturation below 92%, their peak flow reading is between 33 and 50% of best or predicted, the heart rate is more than 140 in children aged 1 to 5 years, or more than 125 in children over 5 years, and the respiratory rate is more than 40 in children aged 1 to 5 years, or more than 30 in children over 5 years. Then we have life-threatening asthma, which is when any one of the following is found in a patient with severe asthma: exhaustion, a saturation of oxygen below 92%, hypotension, a peak flow below 33% of best or predicted, cyanosis, silent chest, poor respiratory effort or confusion. During the assessment, we should document the following: pulse rate, bearing in mind that tachycardia generally indicates worsening asthma, whereas a fall in heart rate in life-threatening asthma is a preterminal event. Respiratory rate and degree of breathlessness, for example, if the child is too breathless to complete sentences or to feed. The use of accessory muscles, which is best noted by palpating the neck muscles. The wheezing intensity, which may become biphasic or diminish with increased airway obstruction. And agitation and conscious level, always giving calm reassurance throughout the assessment. However, clinical signs can correlate poorly with the severity of airway obstruction, and some children with acute severe asthma may not appear distressed. Therefore, in order not to miss these patients, decisions about admission to hospital should be made after repeated assessment of the response to bronchodilator treatment. In other words, frequent reassessment is essential, as clinical signs may not always correlate with the severity of airway obstruction. So that is it, a review of the initial assessment of acute asthma in children. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.